Hi, Dr. Mark Trolice, Fertility Care, the IVF Center. Good day to you. Happy Monday. Very rainy, dreary day here in Orlando, but we hope to pick it up with good video content today. So what's new in embryo transfers? Years ago, we did our embryo transfers on day 2 of embryo development, and then it was a big deal when we went to day 3. Well, around the 1990s or so, later in the 1990s, and certainly in the 2000s, day 5 was the rage, and it's still a good day to do an embryo transfer. That's when the blastocyst embryo develops. So, what drives an embryo to day 3 of development is actually mom's genes, okay, the genetics of the maternal genome. On the evening of day 3, what drives is day 5, and the rest of it is the embryo's genes, okay? So the theory and evidence does support that in good prognosis patients, day 5 blastocyst transfer is superior. In all of the patients, average to low prognosis patients, day 3 is still a good day to do a transfer. The ultimate question and the unanswerable question is, if an embryo didn't develop to day 5, in other words, let's take all of our patients and have them do a day 5 transfer. It's estimated about 10% or so would not have an embryo to transfer. If an embryo doesn't make it to day 5, would it have resulted in a transfer on day 3? We don't know. It's unanswerable. But we encourage it for good prognosis patients, but for others, we look into day 3. But if there's enough embryos on day 3 that we feel comfortable going to day 5, we certainly do that. Sometimes we do a standby on day 3 if the patient has borderline embryos development. So that's the days that we do the transfer. We follow the Society of Assisted Reproductive Technology guidelines for the number of embryos to transfer because we don't want to end up on Oprah transferring too many embryos. The younger the patient, and probably up to age 38, on day 5 of development, we'll transfer a single embryo. Day 35 to 37 is sort of 1 to 2. Above 38 is about 2. And then when you go into above 40, there is opportunity based on the prognosis of the patient up to 3 blastocysts. And this is a different number than you would transfer on day 3. On day 3 of development, it's higher because there are more likely chromosomal abnormal embryos on day 3 than day 5 because they've weeded themselves out to go to day 5. Not to say day 5 doesn't have that, but it's probably less, okay? So the preparation for the embryo transfer, we do a practice embryo transfer in the office with a little baby catheter to know how easy it is to put inside the uterus. If it's difficult, we schedule you for a dilation so that on the day of the embryo transfer, it's easier, all right? The difficulty of the embryo transfer will reduce prognosis. The other things that we do is we check the uterine cavity to make sure there's no polyps or fibroids or scarring or anything that could reduce embryo development. So the preparation used to be a full bladder and giving a Valium. So we don't give a Valium any longer. There's no advantage of doing that for the patient. We used to also do a lot of abdominal ultrasounds. Now we do them vaginally. Okay, and it's so much more comfortable for the patient. They don't come in with a full bladder and having discomfort. So we put the speculum in and we put the embryo catheter into the outside of the cervix, and then we put the ultrasound and we have vaginal ultrasound at the same time. And it's so much easier for the patients and so much more comfortable and a great view, much better than abdominal, okay? So following the embryo transfer, we have your partner right there, and it actually, just to say parenthetically, I can't believe some programs don't want the partner or don't allow the partner in the room. It's such a sacred moment. So we've always had that and we always will. After the transfer, we used to have a patient rest for 1 hour. We don't do that any longer. There's no advantage. We have you literally get up and leave, okay? So the 3 things that, and there's studies support that, of course. It's not because we don't have the room, but studies support that. So the 3 things that are most important to maximize an embryo transfer, okay, and also the reasons for success are the 3 E's: the embryo, the lining of the uterus or the endometrium, and the embryo transfer. So the embryo has to be normal. Chromosomally, that helps a lot. So if you do genetic testing with PGT, then you are eliminating lesser quality embryos. But the embryo chromosomes are not the only reason for miscarriage. 10% of the time they can still miscarry even with a normal chromosome. So there's other parts of the embryo, either mitochondrial DNA or other structural components of the embryo. The second is the lining of the uterus or the endometrium, if it's not developed properly, if the histologic glands in the stroma of the uterus isn't developed properly. There's an endometrial receptivity assay test that we do for patients who aren't successful with embryo transfers, and it looks at the many genes of the lining of the uterus that need to crosstalk with the embryo, and it will tell us when is the ideal day for a frozen embryo replacement cycle. Most women, day 6. It will tell us if we're doing it a little bit too early though. Maybe 12 hours we should do it earlier, or a day earlier, or vice versa for later on. The last is the embryo transfer, and this is where it's extremely important to be patient and gentle. A difficult embryo transfer will reduce the success rate. So if you're not prepared, in other words, if the physician is not prepared, if it's a difficult transfer or rushing or causing some bleeding, then that lowers the success. So we spend a lot of time at the time of the embryo transfer to make it optimal. So I hope all this information was helpful for you to learn about what's new in embryo transfer. Certainly any questions, you can email us at info at myfertilitycare.com, or we'd love to hear from you on our Facebook page with questions as well. Have a great week. See you soon.